just hit the record button and it should be recording now.
Great, thank you. I think, Gail, whenever you're ready, we're ready. I guess it's not officially one.
Yes, I was going to give it a couple more minutes. Give people a chance to sign on. All right, I think we can go ahead and get started today. Just so everyone is aware, this webinar is being recorded and will be available once it's posted to our website. Good afternoon. Thank you for joining us today. It is my pleasure to welcome you to the SHARE webinar. For those of you who may not be familiar with SHARE, it is a joint public health initiative between the University of Arizona Emergency Research Center and the Arizona Department of Health Services Bureau of EMS and Trauma System. The mission of SHARE is to improve survival for out-of-hospital cardiac arrest in Arizona. Our program is unique and has made Arizona a national leader in cardiac arrest resuscitation. Our success could not happen without your participation as EMS agencies and personnel. SHARE is an overall system of care that starts with bystander recognition of cardiac arrest, dispatcher-aided CPR, AED use, EMS response, and ultimately excellent care at Arizona's cardiac receiving and referral centers. As many of you know, I've been the medical director for the Bureau of EMS and Trauma Systems since September 2019. Since January, a significant amount of our resources have been focused on the response to the COVID pandemic. We are excited to have the time to focus our energies once again on the SHARE program. Our goal for the next year is to re-energize the amazing work of SHARE and to find ways for Arizona to continue as a leader in cardiac arrest resuscitation across Arizona. We are going to do a quick virtual introduction before we enter the main portion of today's webinar. Ben, I'll hand it over to you. Thank you.
Thanks, Dr. Bradley. My name is Ben Fisher. I am the Services Section Chief at the Bureau of EMS and Trauma. I oversee the EMS and Trauma Registry, as well as our epidemiologists who help us analyze this data. And I just want to thank everyone for attending, and please know that none of this work is possible without your help. And so with that, I'll hand it off to Allison Welch.
Hi, everyone. I'm Allison Welch, and I'm the Time-Sensitive Illness and Injury Manager with the Bureau of EMS and Trauma. And what that means is I work with the university to make sure that our data is being input correctly, and then also I manage the AED registry portion of the SHARE website as well. So it's nice to have you here.
And with that, we'll go to Bruce.
My name is Bruce Barnhart. I'm the Senior Program Manager at the Arizona Emergency Medicine Research Center. And I have the distinction of being able to work with all of the data that all of you put into the system, and work with a phenomenal team both at the AEMRC and at DHS in trying to input this data and then analyze it, clean it, and understand what is there and what we can reliably get outputs on. So thank you all for attending.
Margaret, if you're available, I don't know if you want to introduce yourself and your role.
You're muted, Margaret.
Sorry, gang. So welcome, everybody. I work pretty closely with the hospitals, coordinating with the receiving and the referral centers. I see several of the hospital contacts on here today, and glad to have you.
Thank you.
I'm
Karen?
Karen Mogi-Miller. I work for the Emergency Medicine Research Center on SHARE with the University of Arizona, and I do the data and application management of the CEDAR as well as AED registry.
All right, and then we're off to Dr. Spate.
Thanks, Ben, and thanks for everybody being here. And Shelley, if you will stop your presenting sharing, then I hopefully will be able to bring mine up, and we'll be, Shelley, why don't you let me present mine so I won't have to tell you when to switch slides. So if you'll come out of present, then if a doctor can actually pull this off, maybe I'm being more optimistic than reality, but is that working?
Yes.
It is.
Great. Hey, if this academic medicine thing doesn't work out for me, maybe I'll go into IT. So anyway, yes. So I'm Dan Spate, and feel free to call me Dan. And I have been at the University of Arizona and an EMS physician in Arizona for my entire career, which has been more than 3 decades, and have the privilege of being on the university side, the director of the University of Arizona Research Center for EMS, and also the director for the SHARE program on the U of A side in our partnership with the Arizona Department of Health Services. And my role this morning will be to try to put many, many years of work into 20 minutes. And so if I was an internist, you'd be in trouble. But given that I'm an emergency physician, I think we'll pull this off. So let me go back. The year was 2004, and a really unique, which still remains unique in all 50 states and 5 territories, an amazing partnership where the Department of Health Services, as opposed to viewing itself just as a regulatory agency and entity, all of a sudden got this absurd idea that a Department of Health Services should improve health. I know it was it was an absurd thought, but in any case, so it was a phenomenal time where the DHS and the U of A, we partnered and then started including what has become way more than 130 EMS agencies. The hospitals had not come on yet, and the Arizona Ambulance Association. And the purpose was to evaluate and improve the #1 killer of Arizonans, which most of you probably know is actually out-of-hospital cardiac arrest. And one of the things that if you haven't been around for longer than about 10 years, you might know. But back in 2004, everybody thought we knew one thing. If we knew anything in EMS, we knew it was the A, B, C's, and in that order. It was the only commandment. In fact, you went to EMS hell if you forgot airway, breathing, and circulation in that order. And that was true except at the U of A. In sudden cardiac death, because of 15 years of pig research, which I'll show you just a couple of snapshots of, because it was so stunning and so heretical, we actually believe that in the setting of sudden cardiac death, not drowning, not respiratory, not those kind of things, but where an adult suddenly collapses, that it actually is the CABs. And so I'm just going to give you a quick run of a convergence that happened in 2004 and 2005, and it was from these 4 things: ventilation, PIGs, interruptions, of course, speaking of chest compression interruption, and death rate. And so at that point, what had become very clear from our work and many others was that positive pressure ventilation is actually a disaster during CPR. Because in really good CPR, the blood pressure only gets up, on a good day, maybe world record, 60, but most of the time it only gets to 40 or 50. So positive pressure ventilation into the chest has a very dramatic increase in intrathoracic pressure, and it decreases venous return to the chest, which is a big deal, obviously, decreasing the outflow from the aorta. And that decreases coronary blood flow and decreases cerebral blood flow. The second was PIGs, right? So ventilation and PIGs. And it turns out that conventional ACLS kills PIGs. And this is a really dramatic look at, we knew this, we had known this already for more than a decade in 2004, that if you do perfect, flawless, conventional ACLS in the PIG model of ventricular fibrillation, that you get ROSC less than half the time in pigs using ACLS. And notice basically at 24 hours, there's 1 in 10 pigs that are neurologically intact using perfect, flawless ACLS, intubation, and ventilation. And 80% of the pigs are neurologically intact, happily eating their food, not knowing what happened to them the day before. And so amazingly enough, we knew that pigs do better choking on their tongues on room air than they do if they get perfect intubation and ventilation. And that's because of what we were learning about ventilation and some other things that I'll chat about in a minute. So why does it kill pigs? Because less than 50% of the cycle has chest compressions in classic ACLS, and interrupting chest compressions dramatically impacts coronary perfusion pressure. And for those of you who have never seen anything like this, just notice that this is the first compression out of 15 chest compressions in a pig. And this is basically the venous blood pressure, and this is the arterial blood pressure. So the spread between these two means that the actual blood pressure producing blood flow is getting much, much better. And at 15 compressions, notice it's actually starting to get quite good. And then, amazingly enough, as soon as you pause to do ventilations, you ready for this? In 3 seconds, you lose all of the forward flow. So, amazingly enough, this is one of the worst historical decisions in history. The arbitrary choice of 15-2 back then meant that as soon as you finally get a good blood pressure during, as good as you're going to get during chest compressions, we immediately had a plan to stop for all of the forward flow to go ahead. And so in classic conventional CPR, this is what was constantly happening, and it was planned and cycled. So this concept at U of A, which we began actually a quarter of a century ago, trying to get somebody to do it in humans, as you can see, when you get continuous compression-only CPR, it goes directly. Next was interruptions. And so what we did is, using mannequins, we got a bunch of really experienced paramedics, and we said, do your 15-2 as quickly and as efficiently as you can, trying to give as little time possible of interruption to do the airway. And as you can see, on average, it took the paramedic 16 seconds to do the 2 breaths. And so in a given cycle, you're only getting 39 chest compressions per minute, and only 42% of the cycle had chest compressions, less than half of the time. Whereas at that point, nobody was thinking continuous. So we went to 50 to 2, and amazingly enough, when we said do 50 to 2, you got to 84 per minute chest compressions, about 120% increase, and 93% of the cycle actually had compressions. And this shows on a mannequin how much more time was being spent without compressions to get these ventilations in than definitely less than half. The other thing was death rates. The fourth thing that launched what we did in Arizona was this. And everybody knows that other than the special DNA and the special air in Seattle, basically everywhere else on the planet had horrible outcomes. And drum roll, this is what we found in Arizona. So almost everyone was dying from cardiac arrest in Arizona, even though essentially everybody did good ACLS. And so there was nothing to lose by making the changes. And at that time, Ben Bobrow and Will Humble made an incredibly courageous decision, because no other state or territory had done it. But they basically said, we're dumping ACLS. Everybody's dying with ACLS. And we're going to go with U of A's construct that was building at that point, both in humans and lots of animal information. And we're going to implement, some of you remember the term CCR, cardiocerebral resuscitation, more technically correct MICR, or minimally interrupted cardiac resuscitation, and in bystanders, compression only CPR. And so Arizona modified at that point the classic chain of survival with a real emphasis on telephone assisted CPR, and then the bystanders specifically. I'll talk about what we did, but compression only CPR for bystanders, and emphasis on early AED. In EMS, adding the MICR, doing passive oxygen insufflation, more on that in a minute, and then really emphasizing CPR feedback, meaning the real time. Some have a puck, others have different mechanisms for knowing how good the depth and rate of compressions are, but using the monitor to actually provide real-time feedback and improve the quality of CPR. And then EMS bypass finally, and to cardiac receiving centers, and I think we have many people on today from the CRCs. Thanks for joining us. So the way we did bystander CPR in Arizona was a dramatic change from anywhere else on the planet. It was a multifaceted approach to increase CPR rates, but it officially endorsed and encouraged and even trained the lay public to do compression-only CPR. So we taught the public that if a person suddenly collapsed, not only did they have permission not to do mouth-to-mouth, but we discouraged them from doing mouth-to-mouth for reasons you've already heard and that you'll see in a minute. And then widespread telephone CPR training and QI programs at the major dispatch centers in the state came a little later. But altogether, that was the package. And notice, this was an amazing thing. First of all, no state has ever shown over such a short period of time an improvement from 28% of any kind of CPR, regardless of what type, to 40. That's a relative increase of almost 42% in CPR. This is really hard to do. As you know, lots of states have worked really hard and basically never moved the needle at all. But amazingly enough, look at this is the percentage among those getting CPR. This is the percentage getting compression-only CPR, and it went from 16%, almost 500% relative increase, up to more than 3/4 of the time in Arizona. If you collapse suddenly, you were getting compression-only CPR by the bystanders rather than classic CPR with mouth-to-mouth. And amazingly enough, statewide, just take a look here. After you do all the adjustment for the things that impact outcome like age and so forth, a 60% increase in survival in witnessed VF. Just a really astounding thing from something so simple, right? And notice what happened in neurological outcome. This is the neurologically intact outcome group. And don't worry about thinking in forest plot. Let me just tell you, that what this means is, in Arizona, from the addition of compression only and telephone CPR, the neurologically intact survival doubled in the state of Arizona, was associated with that intervention. And then don't get bleary-eyed on this. For those who've been around, you understand this, but here's the point. Minimally interrupted cardiac resuscitation jettisoned the concept of what had become 15-2 at that point. The ACLS has baby stepped to 30-2. Maybe in another decade they'll figure it out. But notice the first 200 compressions are completely uninterrupted. So this is the first 2 minutes, quick analysis with a huge emphasis on pre-shock pauses being tiny and post-shock pauses being tiny. If there's a shock, you do it, and then you immediately go back to CPR. You don't wait around to see whether they have a pulse or not. That comes later, and there's always a delay. So this goes 4 cycles before you revert then to doing oxygenation and ACLS. And this was an incredibly important sub-analysis here that showed, notice this was the outcome in witnessed VF, the percentage of people who survived from standard ACLS, and this was MICR before after, and it was a tripling of survival going to MICR versus ACLS. And this is really, really striking. Back then, notice, there were a lot of people who said, okay, we'll go to MICR, we'll go to compression-only CPR as a part of EMS, but we're really afraid to not intubate or to at least not bag the patient intermittently. And so we did a sub-analysis of those who did passive oxygen insufflation, basically just high-flow O2 on a non-rebreather mask versus bagging and or intubating, right? So active ventilation. And this is astounding to think about, but when you do the adjusted analysis in the model, those EMS agencies and medical directors that chose to do passive oxygen insufflation, so no positive pressure ventilation at all, either basic or advanced for the first 8 minutes, look at this, almost a 6-fold greater adjusted likelihood of survival if you had passive oxygen insufflation rather than bag valve mask and or intubation. So remember all the way back there, all those horrible things that positive pressure ventilation does. We have profound evidence in Arizona, observational, not randomized, but observational, but nonetheless really impressive association with positive pressure ventilation leading to death and passive oxygen insufflation leading to survival much more frequently. So a lot of people say, well, what about oxygenation? The bottom line is when a person's heart stops suddenly, the lungs and the circulation are well oxygenated. So the issue is, that's why it's the CABs. The first issue for the first 8 minutes is to circulate the oxygen that's there. And then many agencies added and were a part of this sub-study, real-time CPR feedback. This was an early example of what a dashboard looked like. And so this was telling them, this is in inches, was telling them the depth, it was telling them their rate. And in this particular kind, when the diamond filled all the way in here, that meant you were doing really, really good CPR, including doing a good release velocity, right? Releasing very quickly, which is important. And then this was a timer so that at 2 minutes, you would know it was time to do an analysis. And in those agencies that really focused with us on real-time feedback, amazing, look at this, basically a doubling, this is actually the odds of survival. So almost a 6-fold increase in those who compared to what they had done before, right? So this was before versus after. So this prepared us for regionalization, right? We had bystander compression-only CPR, telephone CPR, EMS was doing MICR, passive oxygen insufflation was being accepted rather than doing positive pressure ventilation, and many agencies were doing real-time feedback. And so we had built the bridge, but at that point, it was a bridge to nowhere because, look at this, in Arizona at that time, it already had been known at that time that therapeutic hypothermia after return of spontaneous circulation was really good for neurologically intact survival. But in that point at 2006, only 2 of 61 hospitals had a protocol for hypothermia. And out of 2,000 ROSC patients that we looked at in 2006, only 4 patients were ever cooled. So here came the cardiac receiving center plan. And in 2007, as most of you know, this was initiated by the DHS in combination with the U of A, and it was completely voluntary and still is. It was inclusive, meaning that all hospitals that could meet the criteria, which I have down below, were invited to participate. So this was not exclusive. This wasn't the state picking who was going to be a receiving center. This was everyone who would meet the criteria could opt into being a CRC. And it was formally recognized by the DHS. And the criteria were, you had to be willing to collect and report, the hospital had to be willing to collect and report the data to the DHS. And our partnership, our data partnership at the U of A. The hypothermia protocol had to be specifically established at the hospital, and a mechanism for doing it, meaning training and whichever approach you were going to use, and a commitment to do therapeutic hypothermia in ROSC patients who were still comatose when they arrived at the hospital. They had to have 24/7 cardiology and 24/7 cath lab with percutaneous intervention available. A commitment to provide comprehensive guideline care, right? Because it's more than just those things. It's pressure support and all types of things, careful management of ventilation in the ICU. And then finally, a termination of care protocol, meaning that once you do therapeutic hypothermia in a patient, you're committed to 72 hours of managing them if they're still in coma, because some people, in fact, now in Arizona, we've had people, amazingly enough, who've woken up after 6 days of coma and ended up being completely neurologically intact and going back to their previous lifestyle, etc. This was really quite amazing, right? The CRCs, there were only a couple early on, but then it took off, and we ended up now, I think we're in the range of 40 to 42, 43 at this point. And this was where the EMS bypass protocol, right, which said that if you are no more than 15 minutes farther from a CRC, that if you have a cardiac arrest patient, you can bypass the local community hospital and go to a cardiac receiving hospital. And this was our publication. And amazingly enough, look what happened after initiating the CRC and the bypass system. As you can see here, in our before analysis, there were no patients who got therapeutic hypothermia. But after implementation, and this wouldn't have been years in, so this was just a ways in, so we're sure it's much higher now, almost half of patients in the after group were getting therapeutic hypothermia. Same thing happened with angiography, right? If you have ROSC, going to the cath lab and identifying maybe it's a left main lesion or whatever. And as you can see here, 175% relative increase in the percentage of patients before versus after who got angiography and potentially got PCI. And this is what happened to survival, quite amazing. With all rhythms, it doubled, right? The odds ratio better than doubled. In all rhythms, the favorable neurological outcome doubled. As you can see here, this is witnessed ventricular fibrillation and ventricular tachycardia, so shockable rhythms. This tripled survival and more than doubled neurologically intact survival. So again, the impact of regionalization and post-arrest care was incredible. And so implementation of a statewide system of CRCs and EMS bypass was independently associated with dramatically improved survival and neuro outcome. And it's worth noting that at that point, all of the previous efforts anywhere in the world had been much, much smaller than a state. No jurisdiction nearly as big as Arizona had ever tried this. And in most places, it was just one or two major hospitals with their EMS agencies that did it. But here was more than 100 agencies, and ended up being more than 40 hospitals involved in this effort. I believe to date, this is probably still the largest in the world. So back to EMS as we finish here, this update. Arizona's EMS agencies and providers created the ability to make the final link in the chain of survival successful. Notice, it was because of this early work, which we've gone through and very rapidly picked up. Sorry if I went too fast. But all of these things were all pre-hospital. and even doing EMS bypass, of course, is a pre-hospital system intervention. And only then, notice, were we in a position for the hospital to make a difference. Because as you know, especially in cardiac arrest, if this doesn't go well, and if you don't deliver a survivable patient with return of spontaneous circulation, the likelihood that the person will survive because of hospital interventions to this day is exceptionally remote. So here's the bottom line. It takes a system of care, and that's exactly what Arizona has created. The numbers have been absolutely staggering with every single intervention the state has done. And this is, I haven't updated this recently, but this is just a whole series of both outcomes and interventions. And you can see what happened in this early days, and we are continuing to implement and even really are hoping for refreshing and kind of share 2.0, if you will, that Gail and Ben will talk about near the end. We always, we can never make any of these presentations without thanking both the pre-hospital providers, the fire departments, the ambulance companies, the dispatchers all over the state, as well as the hospital providers who have staff 24/7, all those kind of stuff for receiving to make this happen. So at this point, let me back out and I will turn it back to the team. I think we may have some time for questions at the end if all goes well. So at this point, we're not going to go into Q&A because we want to make sure we get through everything else. Did my unsharing work?
It did.
Yes.
Perfect, Shelley. We can go to the next slide.
All right.
Okay, this is Bruce Barnhart again. So I'll give the kind of a brief summary of the report. There's, I think, 8 pages total. Specific agencies that had more volume will actually have another 3 or 4 pages. So we won't go over it all in depth, but there's an enormous amount of data to look at. It can make your eyes cross. If it does, please let us know and we will unpack it for you in every way we possibly can. So in 2019, we had 5,345 cases that met our criteria. That was an increase of 345 cases from 2018. That excludes traumas. We collect them, but we do not process that data because it is different. The outcomes, the mechanism, everything else. Go ahead to the next slide, Shelley. So where we came over 2019, we improved about 0.8% from 2018. We were at 10.5 and we went up to 11.3% in 19. To give you an idea, CARES, which is a national database similar to SHARE, except for it covers parts of many states, not all of any single state. Their data was 10.6%. So we did a little better than they did as a state compared to the benchmark of CARES data. 33.6 met our criteria for what we call UTSTEAN, which is a bystander witnessed arrest with the shockable rhythm that does not have a DNR. Our survival rate was 33.6. These are the most likely to survive. This is a 3.5% increase from 2018 survival, and it is nominally better than the CARES data. Theirs showed a 33.1% for 2019. We have 529 survivors. That's over 10 people per week that were discharged alive from a CRC after suffering cardiac arrest. We might have several of those folks on this call today because I know we've had a not insignificant number of EMS providers that have suffered cardiac arrest. So we had 77 more survivors in 2019 as compared to 18, which is a phenomenal result due to your efforts. Okay, next slide, Shelley. So we made some changes to the 2019 report. We decided that we could take data from the largest agencies, which we chose as a metric of either 50 a year in some instances, 50 cardiac arrests a year, or 95 cardiac arrests a year in others. It doesn't really make sense. If you had one cardiac arrest and you had a save, then you've got 100% survival. And if you had a death, you have 0%. And that just isn't very fair. So we wanted to go with agencies that had enough volume that it made some sense to use that. This report will show the listing of agencies. And we had around 32 that had more than 50, and we had, I think, 15 or 16 that had more than 95 a year statewide. We've anonymized it so you can't pick out one agency from the other. If you are one of those largest agencies, you will receive your own data that shows where you sat on that scale, but not what the other agency names are. We want to keep everything anonymized to agency. So you'll be receiving that. Otherwise, if you were in a smaller group, that just means that you'll see the overall listings without any specific identification of which agency is which. They're just anonymized by alphabetical number. Okay, go ahead, Shelley. So what we have found is we have some significant, some opportunities. We had found significant variations noted in our survival between the similar sized EMS agencies. And a lot of times when you get to the largest agencies, they're similar in a lot of other ways too. We found a variation in Utstein survival from 23% to 63%. Now again, Utstein is the most likely to survive patients, only counts agencies that had more than 95 cardiac arrests a year. And again, Utstein means that it was witnessed by a bystander, that it was shockable and had no DNR. If you look at our overall survival, all-cause system-wide survival, we have an 11.3% survival. What we believe is that the survival is probably true in smaller agencies. So we believe there's a significant variation in survival depending on the agency and how well they focus on cardiac arrest and the management of their cardiac arrest patients. Regardless, no matter where we are at on that, we can always get better and do things better in cardiac arrest resuscitation. So we wanted to take this opportunity to refocus our efforts on excellent process management, excellent compressions, excellent rate, excellent on-chest time, short time to defibrillation or between defibrillations, just excellent management. And see if we can continue to improve that, because every little step forward gets harder as we do better. So we want to really, really focus on cardiac arrest efforts. All right, Shelley, next slide. Another opportunity that we noticed was that our time from arrived scene or patient contact, depending on which the agency puts in, because we can only use the data that we get, to first shock. That seems like that should be fairly consistent from a rural agency to an urban agency. There's a lot of metrics that don't work that way, where it's much easier to manage it in the urban environment, or you have more resources or whatever. But what we figured out was that in the time from arrived scene to first shock, it ranges from under 3 minutes to over 11 minutes. And this does not necessarily seem to have anything to do with rural versus urban. It's a focus thing is what we're thinking. Again, we aren't running those calls, so we don't know all of the reasons that the variance is so significant. This is limited to agencies that had greater than 50 cardiac arrests a year. So everything you can do to minimize the time to first shock is really important. We have seen historically that the number of cardiac arrests in VFib and VTAC are going down, and the asystole and PEA arrests are going up. So that number does seem to be getting smaller over time. Another thing that we would like to be really cognizant of is documenting the time that ROSC occurred and then how long it lasted. We've seen a lot of variance in the reporting of that. And that is noted in the charts. That may be a data capture issue. It may be that that feature is not mandated by your EPCR system. So it may be that you have that. It's just not something that we get. If we don't get it, we can't record it. but we have significant variances from, I believe, 90 some odd percent down to 0% in our largest agencies. So that's something that you can do to help us. Okay, next slide. Some other things that we've noticed discrepancies in is the initial monitored arrest rhythm. So if you found the patient in VFib or asystole, it's really important that we know what that was, because that allows us to then incorporate the data into which arm of the Utstein template that we put that patient in. If you're an EMS provider and you witness an arrest, we often find that the original rhythm is noted, but the first arrest rhythm is not noted. So that's something that is really helpful. It's easy to get busy on care and forget to chart that. Rhythm at hospital is very helpful to us so that we can see where we ended up at, because we have to match all of these up. Karen's going to talk briefly about that momentarily. If there's dispatch-assisted CPR instructions provided, again, this may be an EPCR platform problem, but we were able to only document that dispatch-assisted CPR occurred in 0.47% of cases in 2019, so less than 0.5%. And if that's anywhere near accurate, we have to focus our dispatchers on getting CPR actually started on patients. Sometimes we can't find the patient. There's an irregularity in the charting, and it looks like the patient went to one hospital and they may have gone to another, or the name might be wrong. So if you know the outcome, if you know that the patient was left with pulses, that's really helpful. What we find is that death is very easy to track. Survival is much harder, because some of those patients don't actually show that they came in as a cardiac arrest, because they now have a pulse, they now have blood pressure. In some cases, they're waking up. But dead is pretty easy to identify. So patient outcome is very helpful to us. The type of compressions that were used, whether you used CCR, MICR, compression-only CPR, whatever you want to call it, or if you use standard ACLS, and then when you switch to standard ACLS, which should be about 8 minutes in, 4 cycles in, that documentation that you switched to standard ACLS. That's really helpful to getting better data, which allows us to be more accurate in our reporting and give you more data that you can use. Next slide. We also, this is a harder one to deal with, but we saw huge variations in the incidence of cardiac arrest. So for instance, we had 45 per 100,000 population in Maricopa County. And when you go out to La Paz County, much less population, we were up to 190 per 100,000 in population. So that's over 4 times higher. And if you look at some of the other relatively rural counties, we were running in the neighborhood of 75, 70. There's a huge variation in that. So anything you can do to reduce the incidence of cardiac arrest in your environment is appreciated. I know DHS has a lot of initiatives that they're trying to do that. That will be a long-term fix, but it is a substantial difference in that. Okay, next slide. So that's really what I was looking at. There were a couple of other points that I wanted to bring up. We are collecting more in-depth airway data. And if you can document that you did a supraglottic airway, which we don't really consider an intubation. Intubation is an ET tube. But if you put in a supraglottic airway, a King or an iGel, please document it as such. Sometimes we find that as documented as intubation, and we're struggling to figure out whether that was truly endotracheal intubation or whether that was a supraglottic placement. We've been doing a project on mechanical CPR usage. Some people use the puck as they'll check the box that says that was mechanical CPR or a CPR device. I'm not sure how it's written on the EPCR platforms. And that leads us into lots of confusion. We've reached out to a whole bunch of agencies to try and figure out what device they're using to try and unpack that and get better data on that. All airway attempts, successful and unsuccessful, that's really helpful. And I think that is pretty much it. We do use the narratives, but we also rely on the individual fields that you fill out. So we'll be sending out the reports probably today and tomorrow, and you should expect it. If you don't get one, please let us know, and we will make sure you have one in your hand. Thank you very much. And I think Karen is on next.
Okay. Am I coming through fine then?
Yeah.
Great. So we get a quarterly export of peers data, and then we take that data and we import it into SHARE, our CEDAR system, which is the cardiac event data and reporting system that we use. We have a mapping from the peers data to the CEDAR information, and we go through those, we match them then to the hospital data that we get into the system. And that's an ongoing process since we have hospitals inputting data continuously to the system. We then clean the data using an algorithm that goes through the narratives like Bruce mentioned. So it goes through and picks out keywords out of the narrative to help us complete the data in CEDAR that sometimes comes in as either empty or not documented or unknown. An example would be like the narrative has ACIS or PEA or VF, VT to indicate a rhythm, and maybe the data fields came in as not documented. So that'll show up on a report so we can go through and clean up the data. The narrative is really important for finding some of that additional data. Another thing that we can find in there sometimes is when they're called in the field, but it's not immediately apparent in the imported field data that they were called in the field. It's also important for trauma cases because the etiology might come in as unknown, but in reality it's a trauma, and we'll read the narrative to see that it was a trauma and be able to exclude it appropriately from our OHCA database set. And I think that's a good review of how we bring in the data. And I can pass that on. Then I think Margaret's next, right?
Actually, I'm going to pop in real quick. I pretty much covered everything that I needed to cover. But from an EMS guy that likes to take care of problems in 30 minutes or less, this is an incredibly large project of just multiple reams of data, terabytes of data coming in. So the work that Karen and Robin and Margaret do in trying to unpack that is incredible when you look at it, the amount of effort that it takes to try and get the best data we can. We really appreciate all that all EMS providers are out there doing and all the hospitals are doing. Keep it up. It's tough, and documenting is not the first thing that you're trying to do, but it is really helpful in trying to understand what's going on in our system. So thank you. All right, Margaret.
Yeah. Hi, everybody. So as far as becoming or being a cardiac receiving and referral center, a lot of you have been at this for many, many years, and some of you are brand new. But as a recap, if you are interested in becoming a center or already have, what you have done is worked with the DHS to complete certain steps. So to be a cardiac receiving center, you have agreed to certain things such as cooling the patient, submitting data, a termination of care protocol that Dan mentioned earlier. And all those things get approved by the DHS and you become a recognized center. Or additionally, if you're going to be a referral center and perhaps you can't provide some of those levels of care, you are still involved by receiving these patients and sending them to a cardiac receiving center. And so currently we have 5 cardiac referral centers and 37 cardiac receiving centers, all working diligently, day in and day out, month long. And that data gets put into CEDAR, as Karen just mentioned. It's a really thorough database. And there's a lot of checks and balances. So as your data goes in, it gets reviewed. Red flags come up for inconsistencies. Those get identified, and those can get sent back to you and corrected. And all of that amounts to an annual report that the hospitals have available to them and are also in CEDAR. And while I have your captive ear hospitals, I ask that you try and circulate those reports around the hospital to the relevant people. Certainly, it's an incredible wealth of information that's useful to the hospital. And if we can get it into the right hands, it's that much more valuable. So that's a good process. And I also want folks to know that you can ask for individual reports of any data that you provide for us. So for instance, any metric you provide, if EMS agencies bring you patients and you want to know how many STEMIs you had in a given month or how many survived, and there's things you want to look at, we can identify those points and provide you that information. So don't forget to use that resource. It's super valuable. And keep up the great work. We appreciate it.
Thanks, Margaret. I think we'll kind of circle back to Gail here real quick. And Dr. Bradley, I think if you kind of want to talk about the future and what Share 2.0 looks like, and then we can take some questions at the end.
Excellent. Thank you, everyone, for our wonderful presentations today. We have several initiatives that we're excited to bring forward over the next year. One of our first updates was the development of a new logo, which I think you've seen several times today. We've also worked really hard with AEMRC in updating the annual share report, along with this webinar that we're putting on today. We are going to be working to update and improve our share website and resources, and also really working hopefully in 2021 on a reimagined model of MICR education to help standardize this across Arizona. And ultimately, we really would like to improve collaboration with our cardiac receiving and referral partners. We are confident that with these efforts, we will allow Arizona to continue as a leader in cardiac arrest resuscitation. So thank you to everyone for participating today. I will go on mute, and then it looks like we do have some questions, and Ben, I'll let you lead through that.
Yeah, and there's a Q&A feature on the activities tab, which looks like some shapes if you see it, but you are also welcome to type things in the chat box. The presentation will be recorded and posted on our website, and we will distribute a link as well, but you can also check the ADHS YouTube page, which is where most of our presentations get posted after the fact, usually about 2 or 3 days after the presentation. So with that, yeah, we'll open it up to questions, and I'll stop talking and let the AEMRC team answer your questions.
Ben, this is Dan. Yeah, several came in related to some of the physiological questions and treatment questions. But first, I just wanted to highlight and emphasize what Gail just said. One of the problems of cognitive dissonance in Arizona has been that after the passive oxygen insufflation publication that we published, I think, my goodness, in about 2010, basically everyone in Arizona in EMS does passive insufflation and delays positive pressure ventilation until after 4 cycles of compression. And yet, every 2 years, they recertify an ACLS, where you're, of course, taught to do positive pressure ventilation. In fact, the only place on the planet you currently officially get taught to not do any active ventilation for 8 minutes in resuscitation is in Arizona. And so what Gail mentioned will be, we hope, coming, and hopefully the DHS in partnership with others will be able to minimize that cognitive dissonance that so many have had, that you get your ACLS card and then you promptly go back and you say, well, I'm not doing that. We don't do that in Arizona. So hopefully that will markedly improve. So let me just respond quickly in case there are other questions, but 2 really interesting questions. Let me start first with the simpler one. Dave Harden asked, do we know if continuous chest compression was ever explored when BLS CPR was first explored? And historically, there's no evidence of that. We are unaware of it. And in addition, the place that would have been potentially able to come up would have been the OPALS study, the Ontario Pre-Hospital ALS study of more than 20 years ago. Probably many of you are familiar with that. But the reality is the only place we knew that that not doing ventilations was better was in the pig lab at U of A at that point. And it was just so early that nobody was ready to roll it out. So the reality is when we rolled out in Arizona, probably somewhere in the range already of 80 to 90% of all patients that had cardiac arrests in Arizona were being cared for by ALS/BLS agencies. And only a tiny number of patients were BLS-only agencies caring for them. So we never specifically rolled out the concept of MICR in BLS-only settings. We always included everyone, especially because BLS-only agencies that end up with a successful ROSC often have a backup ALS agency that's coming in, so they had to be able to work together. The one that's even more fascinating is Dave's question about, let me just read it, with passive insufflation showing positive results. Have there been any discussions on recommending adding a limited supply of oxygen with a Venturi mask, or I suppose almost anything else, being included with AEDs, with the obvious understanding that oxygen's an actual drug, that it would be being given by a non-medical person, but we do already have them shocking patients by non-medical people. That is a great idea that has had limited discussion. The reason why is it's really hard outside of Arizona to find anybody who's really focusing on not doing any positive pressure ventilation. You would think with the hands-only CPR movement by the AHA for bystanders that they would be prepared for that, but it's very interesting that the idea of blow-by oxygen or passive oxygen or high-flow O2 non-rebreather oxygen or Venturi mask oxygen is, to my knowledge, has not been extensively discussed, and I'm not aware that it's been studied anywhere. That would obviously be a great potential pilot in the state of Arizona. Great idea, Dave. And I'll turn it back, Ben, to you because I might have missed other questions, or there may be questions for others.
It looks like there's one question about whether or not there will be plans to provide the CCR training to law enforcement officers. I don't know if Bruce or Dr. Bradley, if you're able to answer that.
We have been working on incorporating the law enforcement officers into the EMS system. Stop the Bleed, Narcan, law enforcement is getting drawn into EMS in some format, and often law enforcement is actually the first ones on scene. So we are working very diligently on trying to do that. I know there's some efforts. Several people have been really working with us to try and make that happen. And COVID's made things difficult, but yes, we absolutely want to have law enforcement involved. They provide CPR a lot of the time. I think they are second in a unpublished work that we've been developing. I think they're second below bystander, family bystander in provision of CPR. So we are very interested in that. That is a good example of the efforts that you guys put in. We looked at every unknown bystander CPR case this last year to try and identify which ones were law enforcement, because a lot of times they're not identified. They're just listed as somebody who's doing CPR in the data that we get. So we actually looked at the narratives to try and figure that out. We're working to develop that into a better data that's usable. It's still rough, but we're working on that.
This is Dan. I would say that it would be great for us and Gail and Ben to figure out bridges to law enforcement, because when you think of it now, the simplicity, ACLS is complicated, but the simplicity of MICR is if you had two officers, and as we know, in lots of places in Arizona, officers show up before an EMS. That's very common. So if an officer had the ability to supply high flow oxygen, much like Dave's question, which should not be complicated, had been trained in compression only CPR, good quality CPR, and had an AED, the reality is they would have the essence of what has been game changing for MICR in EMS. And so in some settings where they may precede EMS arrival by 4 minutes, 5 minutes, 6 minutes, there is the potential for a substantial number of early saves by law enforcement. And I realized that the Department of Health Services and the Department of Public Safety working together, that it would likely take that kind of level of cooperation. But because they don't need ACLS, they need some incredibly simple things, and they can essentially be a really good bystander. They can almost do MICR if they were properly trained and if they were authorized to do so. So I think that's a brilliant question, and timing is great.
We got another question. So a question about increasing AED use and availability to law enforcement officers. That's something the Bureau certainly supports, and we'll do what we can to help you and get them registered. Unfortunately, we don't have funds or actual AEDs to give out, but yes, we certainly support law enforcement agencies carrying AEDs. There was a question also in the chat about heart-safe communities and whether or not an HOA could be recognized as a heart-safe community. I'll let Allison answer that one. I know businesses and whole communities can be recognized, but I don't know about HOAs.
Yes, so communities, organizations, as well as businesses and cities can also be recognized. So there's not necessarily a limitation on it. It would, instead of being a heart-safe city, it would be a heart-safe community or heart-safe organization. The application is still on the website, and all the details on the requirements for that, including all outreach and education and training and so forth, are listed on the application. And then you can submit that to AZDHS.
Great, thank you. We're kind of coming right up on time here. I'm not sure if there are any other questions to squeeze in here, or if Dan or Bruce, if you have anything else. I do want to say, thank you to everyone who participated in this, and we certainly appreciate the work of the EMS agencies who have put all this time and effort into collecting this data and doing good CCR in the past. So I do want to say thank you to all of our stakeholders. And as I mentioned, a copy of this recording will be available on our YouTube page probably about 72 hours. It looks like there's a question about who to get past share reports for their agency for either Bruce or Margaret.
The best place to get that is to email me, which is BJB Bravo Juliet Bravo 1 at Arizona spelled out .edu, and we will be happy to get whatever data we have for your agency. Yeah, Shelley just posted it there. We also will be having an evaluation, and if you would email me that, we'll send you an evaluation, and then you can get continuing education hours. We'll send you a CE form with a completed eval. So again, BJB1 at arizona.edu.
All right.
Ben, just one last word from
please.
Dan. I just want to thank you and Gail for your leadership in, there's still so much more to be done, but no place can do it like Arizona. And we are just really grateful to see how the Department of Health Services has remained with that focus. You, of course, have regulatory responsibilities that by statute and rule you have to do, but to see that the focus really still is on being a part of the partnership to improve outcomes in Arizona, and the #1 killer of Arizonans is incredibly helpful, and we're excited for what's going to happen in 2.0. Thanks, everybody.
Yeah, thank you all.
Thank you, everyone.